Hi, I'm Bill Santamour, Managing Editor of Hospitals and Health Networks magazine. With me is Rich Umbdenstock, President and CEO of the American Hospital Association. Rich and I are here today to talk about the federal healthcare reform law. Thanks for coming in.
My pleasure.
Rich, why did the AHA support the legislation?
Well, we've been in favor of reform actually since the 1970s. We've seen the need for change. AHA has been very consistent, 70s, 90s, and now in this most recent discussion. And we had spent about 3 years putting together a framework on reform, the essential elements of reform from the hospital point of view, called Health for Life. And we felt that we were able to, early on, through discussions with the White House and the Senate Finance Committee, shape the beginnings of this bill in a way that was very consistent with Health for Life. So there were a lot of details to be worked out, but we've been hopeful that we could effect some major pieces of reform right from the beginning. There's more to be done.
What are the best attributes of the law?
I think everybody who's been in favor of it would look at the 32 million Americans who now have coverage. Yes, it is expensive to provide, but we're already providing care for those individuals. They don't bring payment with them, so it goes into the cost shift, it goes into hospitals' reserves, physician pro bono time. It gets covered. Every dollar of care gets covered, but not in a very efficient way, and not in a way that brings those individuals into the system early for the best care at the right time in the right place. We're hopeful that that big step forward on coverage will help us move toward a better system of care for those individuals, but for everyone, because of the ripple effects that the uncompensated care phenomenon has caused.
What would you say are the most problematic aspects of the law?
Well, it's a huge bill. When I had the chance to meet with Secretary Sebelius about 2 months ago, I think she summed it up well. She said she was fearful of every other paragraph that started "the Secretary shall." There will be a lot by way of implementing regulations. So yes, I think anytime you open up the issue of healthcare and change in the system of healthcare, everybody has an aspect that they want to see changed. So I don't think there was any escaping the size of the bill, given how complex healthcare is and how many different important points each party or each individual sees in healthcare. So the sheer volume will be a challenge for the federal government. It'll be a challenge for the AHA to try to affect those regulations. It'll definitely be a challenge for our members in the field to implement them.
What are the most immediate aspects that the hospitals have to deal with? What should they be aware of right away?
Well, I think that there are a couple things. Certainly there will be changes early on in health insurance, and largely, I think, for the better, certainly for the individuals involved, but also for hospitals. Hospitals will need to know what those changes are and how to both accommodate the changes and help to think a little farther ahead on how to get more people enrolled in the new insurance as it becomes available. So there's that area of change. But we've said all along that there's also a series of changes already underway. The field is integrating more. We are more at risk financially, and we're being held to a higher standard in terms of public accountability. Those changes are already underway, and this bill builds on those, and we have to know what those features are and how to kind of work them into our ongoing efforts.
There's obviously a push for clinical integration. Does this law address that?
Well, yes and no. The way we've used the term clinical integration, we've been thinking about the handful or so of major laws and regulations that inhibit hospitals and physicians from working more closely together and integrating their efforts. The private annulment from the IRS, the antitrust laws, the Stark law, and so on. This law does not change those laws and regulations, so we have to continue that effort. But the law does put into place demonstration projects around accountable care organizations, and it lets the Secretary lower the legal and regulatory barriers in order to do these tests and demos, and that'll teach us where to go in the future. So in that sense, it starts that process. We'd like to see more immediate relief, but we're happy that we're headed down that path.
There are lots of demonstration projects under the law. How do hospitals get ready to participate in those?
Well, the regulatory process will be key to tell us exactly how they're going to use those provisions, exactly what those tests and demos will focus on, what the rules of engagement will be, when they'll be ready to open them up and start to take either state participation or provider or network participation. So the regulatory process will be key to understanding that.
What's the role of the hospital board in implementing some of this?
It's a fascinating question. The board clearly has to see its central role as keeping the institution in sync with the environment in which it operates. Somebody once told me that mission is the intersection between the founding principles and the real world of that year. And I think that's a terrific understanding. Well, the real world has now changed yet again because of this bill. So a board has to start to rethink not the mission itself, not the fundamental principles that they stand for or their fundamental purpose, but rather how you express that in a changing environment. And so in an environment that is more integrated, if you're not part of an integrated system or a multi-hospital system, you might have to think about how will you interface with a more area-wide accountable organization of some sort. If you're not linked up with physicians, don't employ physicians, how are you going to do that if the world's moving that way? So it's not so much what the board wishes or doesn't wish, but rather how you express that fundamental purpose and reason for existence in a new world.
Are there things that hospitals should do now to prepare for the cuts that are coming through the law?
Well, you know, the last 2 years have been really difficult years economically for hospitals, and so they've been really focused on cost control, whether it is in redesigning work and making their use of their human resources more efficient, looking at their cost of goods and services purchased, really looking at entire programs. The economic downturn has put everybody into a very dramatic cost reduction mode. Even if the economy comes back somewhat in the coming year, it'll be very important to hold those gains because whether or not we had health reform, the cuts, the pressure, financial pressures were coming at us. And so in a sense, I think that hospitals are already well into that mode and ahead of anything brought into effect on these new because of the new law.
Is there anything that rural hospitals specifically have to be alert to?
Well, first of all, from the point of view of the critical access hospitals out there in the rural regions, this bill and the payment changes don't affect critical access hospitals. So there are fewer changes in that regard. There are some good provisions around rural issues and rural programs, particularly extending some of those that were due to expire. That's a good thing for the rural hospitals. Probably the biggest question will be, how will some parties in each geography understand the accountable care organization strategy and deploy that in a given region? And so rural hospitals will have to decide, particularly those that are freestanding, how they interface with one or more of those in their market. So it'll start to, I think, raise some organizational relationship and functional issues that hadn't had to be addressed before.
Does the law effectively address the shortage of primary care doctors?
The law takes some really important steps in terms of boosting the payment of primary care physicians. It also reallocates some existing but unfilled residency slots with a favor or a lean towards primary care, rural areas and other underserved areas. So in that sense, I think it has taken some important steps. One of our disappointments was that we didn't get an increase in the total number of graduate medical education slots, and so we fell short there.
What resources will the AHA provide over the coming months for hospitals?
Well, we've been, for the last year, trying to turn all our efforts towards one of three major domains on behalf of our members. Of course, advocacy is always an ongoing priority. Long-term reform, culminating the first phase of that in this bill, but there are things that we still have to address down the road, so we'll continue to work on that. But then the third is performance improvement. That's a number one priority for our members day in, day out. How do they get better in terms of quality, safety, operations and efficiency, and the like? And so we're turning all of our education programs, meeting agendas, the work of our personal membership groups toward more of an emphasis on how do we support that ongoing effort out in the field. We do that in a couple of ways. One is certainly to identify the best practices that are being deployed out there and to showcase those as kind of a knowledge transfer strategy across the membership. AHA is not going to develop those best ideas, the field does. We help transfer that information. But also we've greatly expanded our research capabilities through HRAT to learn what works best in the field and to actually quantify the impact of different strategies or the success of different strategies. So we'll be working on that as well.
Going beyond healthcare reform, what are some of the other priorities for the AHA in 2010? Well,
we've got right on our plate this spring, probably by June or so, we should see the final rule on health information technology and the definition of meaningful use. We provided extensive comments from AHA, and the field provided extensive comments directly to CMS around that proposed rule. We thought that it tried to do too much too soon. We didn't argue about the ultimate goal. We didn't argue about the ultimate timeline. But we thought that there was a better way to get more hospitals adopting HIT quicker and moving those stimulus funds out there faster. Now, we also have other annual priorities. Certainly a big one coming up in the spring will be the inpatient rule for fiscal year 2011, starts on October the 1st. There you might, members I know will remember that last year there was a proposed behavioral offset because of the change in the way in which Medicare was coding for inpatients. And that got delayed through a lot of efforts in the field, but it's going to come back at us again this spring.
When you say spring, you mean?
Well, we expect it in the May-June timeframe. So that'll be another big issue. And then, of course, we've got our annual cycle of extensions and regs and other things.
Well, thanks for talking to me today, Rich.
My pleasure, Bill. Thank you.